Hello, I'm Dr. Simon Johnson and I work closely with TSC patients with LAM. And now I would like to share my experiences with you. If I'm following a TSC patient with symptomatic LAM, then normally I would recommend a medical review. So we would see if his or her symptoms had changed or progressed since last time, and if he or she had any respiratory complications, such as pneumothorax, also known as a collapsed lung. Some patients with more advanced disease get reasonably frequent respiratory infections as well. So we would review the symptoms and determine if any new action was needed. I usually have my patients' lung function tested at review visits because I like to see whether their lung function is stable or at what speed it's declining. It helps me guide treatment decisions. Personally, I don't request lots of follow-up CT imaging because of the radiation dosage. However, I will repeat CT scans sometimes if the patient's symptoms and lung function don't correlate very well, just to make sure I'm not missing anything. So mostly, I assess a patient's medical status with a clinical history, exam, and pulmonary function test. I may do a plain chest film from time to time and CT imaging less frequently. If LAM is not present in a TSC patient at age 18, pulmonologists do not know whether this lung disease is going to develop over the next few years. And certainly if patients develop respiratory symptoms, then reinvestigating them for LAM, providing a sufficient amount of time had elapsed since their last scan, would be appropriate. At the moment, the European guidelines suggest that the patient have follow-up CT scan later on, approximately 10 to 20 years after the first CT scan, to see if LAM has developed. Usually, if the patient has symptomatic disease, especially if there is evidence that lung function is deteriorating, I'll probably see them 3 or 4 times a year. If I'm considering a treatment or intervention, the disease is active, they have a collapsed lung, or if they're getting a lot of infections. Then when things are stable, I'll probably see them maybe twice a year. For patients who are very stable, have minimal disease, or have normal lung function, I'll perhaps see them once a year, or maybe less frequently than that, just to make sure that things are staying stable. Usually, I will give them general advice, such as warning them to avoid estrogen, and what to do if they get symptoms of pneumothorax, a collapsed lung. So again, it's tailored to the activity of the patient's disease. TSC patients with LAM often have renal angiomyolipomas, or AMLs, and so may benefit greatly from abdominal CT imaging. Often, AMLs are large, complex, and prone to bleeding, so determining whether they are likely to need treatment early is a very important benefit from doing abdominal CT. Patients with LAM also have other abdominal complications. They might have a build-up of chylous fluid, a milky substance produced by the body in the abdomen. They might have enlarged lymph nodes, or they might have these saccular enlargements of the lymphatic tracts called lymphangioliomyomas. In my opinion, these are a little less common in patients with TSC LAM than sporadic LAM, but if the patient has abdominal symptoms such as distension or bloating, lymphangioliomyomas might be a potential cause for this. Therefore, an abdominal CT is a good plan in patients with TSC LAM.